Hello, 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 everyone. It's me, Dr. Toomer, and Dr. Toomer Talks on Tuesday. Don't you love those alliterations? And I am here with Dr. Carolina Sweldo, who I'm going to let introduce yourself because she's amazing. She's an OBGYN. She's an infertility just extraordinaire, doctor extraordinaire. She does a lot of media and she's an influencer because I follow her on Instagram. So anyone I follow is an
Thank you.
influencer as far as I'm concerned. And so I'm going to let her introduce herself, and then we're going to get right into some issues that I know that people who follow me are very interested in. I'm sure who also follow her are interested in as well. So take us away.
Absolutely. Well, it's hard to beat that introduction, Dr. Toomer, but thank you so much for having me on tonight. So for those who don't know me, as she said, Dr. Carolina Sweldo, I'm double board certified, both in OBGYN and REI, which stands for infertility. That's kind of the bulk of what I do, but I also do hormone disorders. And I've bounced around a bit. So I did my residency training in California at UCSF Fresno. I did my fellowship in the Northeast at University of Connecticut. I was with a large practice in South Florida for 3 years. And then I just spent the last 4.5 to 5 years in California. And literally, we were just talking about this before we went live. In the last few weeks, I made the move back to Florida. And that was really a family-driven decision. My husband's born and raised Fort Lauderdale, Florida. And he really liked the town we were in, but California, he just never quite acclimated to. So he gave it a good try.
Okay. Well, I definitely understand that move. I moved from Michigan to Florida and then to Georgia and South Carolina. I'll never go back to Michigan. I love the weather for no other reason.
Yeah, exactly.
So one of the things we wanted to talk about is because, as everyone knows, I'm the CEO and founder of Health, Wellness, and Weight Loss Centers, and I run my group. One of the things that comes up often, and people come to me often, is because they're trying to get pregnant. They have usually polycystic ovary syndrome, but other things that create issues with obesity, and they're having difficulty with getting pregnant, and they're having infertility issues, and they come to me to help with weight loss. How effective is I know the answer obviously, but how effective is weight loss in helping people who are having some infertility issues in helping them get to the point where they can get pregnant?
Yeah, I mean, I think I cannot underestimate the impact that weight loss has on the fertility journey. And when I'm interviewing patients, that new patient consult, we're doing a deep dive into the patient's history and their health, their general health is something we're going to talk very much about. Do they have an elevated BMI or are they obese? Which right now, and you know more about this than me, but BMI is maybe not the best parameter, but it is what a lot of us use just in our general everyday practice. Do we have diabetes or insulin resistance? Do we have high cholesterol, high blood pressure? A lot of the comorbidities or medical conditions that come associated with obesity. And what we see, it's been very well documented, it's very well established in the literature that extremes in weight, both up and down, so I want to be clear, both of them have an impact on reproductive health. Now, specifically obesity, there's a couple different ways that it happens. One of them, which is probably the easiest to explain to patients, is that there's an enzyme in the fatty tissue that makes estrogen. And so what happens, or the way I counsel patients, so imagine that for a normal functioning reproductive system, the brain and the ovary have to talk to each other clearly. So like you and I are having this conversation tonight. If you have that estrogen circulating from the fatty tissue, then all of a sudden, those two people, the brain and the ovary, they're trying to talk in the middle of a crowded conference room. So the communication gets very muddied. And a lot of times ovulation, which is the release of that egg every month, becomes impacted. So it's a lot more complex. There's a lot more that goes into it, but I think that's the easiest way to explain it. Clear one-to-one conversation versus a crowded conference room. So a lot of times women with obesity present with irregular cycles. And so obesity in and of itself is a risk factor for irregular cycles, but I will be clear, it is a diagnosis of exclusion. You can't just look at someone and say, well, that's why your cycles are irregular. As you mentioned, polycystic ovarian syndrome, that's the number one endocrinopathy or reproductive, lack of ovulation disorder in reproductive age women. It affects anywhere from 8 to 13%, depending on the study, of reproductive age women in this country. So it's very, very common. And the management of PCOS, while linked and correlated, is still different than if you're just treating the obesity. So it's really important that the doctor that you're working with does that deep dive and really understands what is at the bottom of your or at the bottom of your symptoms. What's the diagnosis? We do know that obesity also impacts fertility in other ways, though. So it's not just irregular cycles. We see that those patients have an impact to their egg reserve, which is the egg quantity, as well as the egg quality. So those are studies that come from IVF patients. And the reason we look at IVF patients is because we're looking at those eggs and embryos under the microscope. So it gives us a more detailed assessment. And what we find is that egg quality is typically not as good as patients who do not have obesity. We also see that from a procedural standpoint, so getting the ultrasounds done, getting the egg retrieval done, those patients tend to be more difficult and have a higher risk of complications. So now you have sort of all the side effects of treatment, you have the stress and all the anxiety of infertility in and of itself. On top of that, you're adding that additional risk factor to the treatment. And then as far as pregnancy is concerned, we do know that women who have obesity have an increased risk for things like miscarriage and pregnancy complications, diabetes or gestational diabetes of pregnancy, preeclampsia, and something called intrauterine fetal demise, where the baby dies in utero of unknown reason. And so all of these things are heightened risk. Why wouldn't we want to optimize that before we begin our family building journey? Now, I'll just add, and I'm sorry, I know I talk a lot and I apologize.
No, it's okay. It's great.
I want to add one other thing to that, though, is that when I'm talking to patients, I'm really looking at the whole picture, because it's not the same to have a conversation with someone who's 22, PCOS, where really taking a year or two to focus on their health journey can make all the difference in the world. They hopefully wouldn't even need me, versus somebody who's 38 or 39. Maybe she has high blood pressure, maybe and so the timeline and the risks and whatnot are completely different. And those are two very different conversations. So I just want to be clear, while I try to give these generalizations, that really it needs to be individualized counseling.
Well, before I continue, I just want to say hello to Dr. Gilliard, who signed in, who came in, say hello. And also, if you're watching now, please say hello. And if you watch later, please put #replay so we know that you've seen it. So one of the things that I talk to people often, particularly when helping people with weight loss during their childbearing years, is to expect an increase in their fertility. So I always do a birth control at least method, or at least just to ask, are you trying? If you're not, and whatever. So when someone says, we talked about BMI, and we know that's not really a great measure for anything other than we just kind of use it arbitrarily. But is there a level where people can get to? It's like, what's the bare minimum of weight they can lose before you start seeing a change in their fertility level? Is there one?
So specifically in the PCOS population, that study was done. And we did see that in women who had PCOS and obesity, if they lost approximately a 10% of their total body weight, that we actually saw in the majority of patients, the resumption of normal monthly menstrual cycles with positive ovulation.
Oh, good to know. And so when I often have people come to me and of course are on and asked to be treated, especially now with the GLP-1s that are out on the market. And they actually reduce the efficacy of birth control pills. We know that. So when someone is trying to get pregnant, is that safe for them? Because I get this question often. If I'm going to try and get pregnant, but I want to lose weight, how safe is it for me to take the medications? Now, I always recommend they stop it if they are pregnant, or if at some point. But what about beforehand? Does it interfere at all with the fertility issues?
So I'm going to make one blanket disclaimer that is really they're so new that we just don't have a ton of data. So we're still trying to parse out what exactly the risks are. That said, the manufacturer, at least of Ozempic, but there are a few others, they talk about a 2-month washout period from the time you stop the medication to the time you become pregnant. And the reason that they give that 2-month washout is because that is the longest time it could take for the medication to cycle out of the system completely. Really, truly, we don't know if there are any risks to the baby or to the pregnancy. So these are all theoretical risks. But for now, because they're so new, we do talk about that 2-month washout period. Now, so basically patients who are coming in and who are wanting to become pregnant, and again, that's where that individualizing the 22-year-old versus the 39-year-old scenarios, I am very pro these medications when they're already doing all of the things and under the supervision of somebody or a physician who knows what they're doing with these medications. Those are like my 2 key things. Because I have so many patients like you who have struggled with weight most of their life. So this is not a new thing. And we now know as physicians, as a medical community, we're more educated that it's not just eat less, exercise more, that there are real hormone changes. And you know this better than I do. I don't know what I'm talking about right now.
Okay. No, it's good.
But basically that, it's going to take them, it's just not the same clinical picture. So for the patients who are already doing all the things and who are working with a physician who knows about these weight loss medications, I am fully in support of adding this as a treatment adjunct, as long as they are not planning pregnancy within 2 months. So this is someone who's maybe in the initial testing phase, or maybe they've decided they want to bank embryos. And so they're not actually planning to become pregnant for, 3 to 6 months. Or maybe this is someone who's considering egg freezing to preserve her future fertility. So that is someone I would not take off the medication. They would just go through the cycle. So really the thought is that 2-month washout period, we want to think about, okay, what is the time that they are planning to get pregnant? If that's immediate, then no, I would not start the medication. But if that time is deferred, whether it's, a spontaneous conception or an embryo transfer with fertility treatment, then you want to consider that 2-month window.
Okay. So I just want to reiterate a little bit of what you've said so far for anyone who's just listening now, joining in. So, a 10% weight loss does positively impact fertility. And we know this particularly with PCOS. Is that correct? Okay.
Yep.
So one of the things I wanted to ask, now I test for and find a lot of insulin resistance, essentially with very high insulin levels, even with the normal hemoglobin A1C, which is what we look for those who are listening, to check for diabetes. And so it's sort of like the low end of the continuum of diabetes. How significant is that in terms of fertility outside of PCOS?
So we know that, and we're learning more and more every day, but at the level of the ovary, there are actually insulin-like receptors. And without getting too molecular, I'll just say that high insulin levels are no bueno for the ovary. It impacts the hormonal milieu and ultimately can be a worsening component to that eventual PCOS picture. We also know that PCOS patients are at a 4-fold increased risk of developing diabetes compared to somebody of the same height and weight that doesn't have PCOS. So those patients really need to be checked and screened yearly because there's such a high rate of conversion.
Okay. And so then my question is, if someone wanted to work with you, where would they find you, and who do you actually work with? If are there specific areas? Are there where are you licensed, first of all? So like, is it states, do you have telehealth? Do you have whatever?
I know. I appreciate the question. So I'll make it easy. So I am currently licensed in 2 states, the state of California, the state of Florida. I do not plan to ever give up those 2 licenses. I will have those until I retire from medicine. I am currently seeing telehealth patients through my old practice in California. And, we can put that up after. But really the focus now is if people want to find me, I'm across all social channels, Facebook, Instagram, YouTube, and my website. And they're all Dr. Carolina Sweldo. So my website is www.drcarolinasueldo.com. You can go on there, send me a message, and we'll get you scheduled for telehealth services. I'm hoping for a physical office location sometime around the Labor Day weekend. So in terms of who I serve, really I serve people who are trying to do family building. So the infertility population is the bulk of who I serve. That said, as I mentioned in the beginning, I am a specialist in hormone disorders. So patients who are presenting with irregular periods, a diagnosis of PCOS that they're unclear or unsure about, very painful periods like endometriosis, those all do fall into my wheelhouse. And if it's something that you maybe want a second opinion or a little bit deeper dive, maybe a more whole picture, whole person treatment approach, which I do believe in, I would be happy to serve you as well. So, family building and infertility is primarily what I do, but I do have many patients who are not seeking pregnancy who have other endocrine or gynecologic issues.
Okay. At what point should someone consider that they're having an infertility issue?
Yeah, that's an awesome question. So part of the reason that I'm online is because I am passionate about empowering women by educating them about their fertility. There's just such a baseline lack of knowledge, even in the most educated circles. So this is something, that's why I'm here tonight. This is something that's super important to me. And that question is really like a key statistic. If I can move that needle, it would be huge for women in this country. And the idea is that if you read textbooks, women under 35 having unprotected intercourse for a year now have a diagnosis of infertility and warrant an evaluation. If you're over 35, that shortens from 12 to 6 months. So over 35, 6 months unprotected intercourse, you need to see someone. And then there's sort of other qualifiers, right? Known risk factors like endometriosis, previous abdominal surgery, cycles that are irregular, you don't have a way to track your ovulation or to time intercourse. Those all are patients that need to be seen sooner than the 6 to 12 month mark.
Okay. Well, I just want to say hello to my Aunt Cynthia, who's watching right now, and also to Chris, who joins us every week. Sometimes, honestly, if Chris didn't join, I would think I was in the wrong place. So thank you for joining in.
Hi,
Chris. So when someone comes to see you, what should they expect? What would you like people to know so that you can manage their expectations appropriately? Or even if you or someone else in their situation, what would you say is the best way to manage their expectations as to what can happen and what should happen next?
Yeah. So I think the best way to manage expectations is that the family building journey, when you need the help of a fertility specialist, is going to be a marathon, not a sprint. It's not like you come in for one visit, bing, boom, bam, and you're pregnant. This is really going to be a relationship. And so you want to make sure that you have really good rapport with your doctor, because you're going to be with them, hopefully not long, but you will be with them at a minimum for a few months. For that new patient consult, you can expect a really deep dive into your history. If you have a partner, we would be doing a deep dive into your partner's history as well. The goal is to try and identify any risk factors that could be contributing to the difficulty getting pregnant. Now, some fertility specialists do like to do a vaginal ultrasound at the time of their new patient visit. Some like to do a physical exam at the time of their new patient visit. So I highly encourage, if you are making that new patient appointment, you do want to have a clear understanding of what's involved. Is it just talking, or should you go prepared for a more invasive type of exam? And then the next thing I'll say is, ideally, you want two people listening in on that consult. That first consult can be very overwhelming. You're already nervous going into the visit. And so whether it's on the speakerphone, FaceTime, or in person, having a support person there to really hear, you have two sets of ears hearing the information is really productive. And then, really self-advocating, I think, is a huge thing. I think a lot of times, patients wait for the doctor to tell them. I have so many patients who, oh, my OBGYN never brought it up, or, I was never referred until I found you myself, 3 years into my trying journey. And so I would really say, just be proactive about asking those questions, whether it's to your OBGYN or your primary care provider. And for most fertility specialists, you actually don't need a referral. You can call and make the appointment yourself. So I think that's something for patients to know as well.
That's good to know. And so I had a question right on the tip of my and I lost it.
You lost it.
I hate when that happens because I don't write it down because I'm always like so focused on what you're saying. But so I do want to know. So we did talk a lot about the effects of estrogen that is more prevalent when you have adipose or adiposity or fat cells, and so therefore obesity can affect fertility. You also mentioned, though, and I talk a lot about weight health. Now, people say I'm a weight loss doctor. I'm actually a weight health doctor. I actually help people gain weight too. So you talked about the other end of the spectrum.
Yep.
So you said if you're overweight, but also if you're too far underweight, it can affect your fertility. Can you explain that just a little bit?
Yeah, absolutely. So there's really two mechanisms that we believe the low weight side or the low extreme can impact fertility. And so one of them is really simple, which is most of this, well, not most, all of the sex hormones are steroid based, which means they are cholesterol based, which means you need some fat, good fat, to help make those sex hormones. So if the body doesn't have any of that fat, then those hormones go away. Okay, so that's number one. And mechanism number two is think about the body going into survival mode, right? So when the body is in starvation and that low weight, we see the body go into survival mode. When you go into survival mode, your body shuts off all non-essential functions, and reproduction is considered a non-essential function. You're now trying to just make sure that your heart is working properly, your liver is functioning, your brain is okay. And so we see that in those patients who have extreme weight BMI, low BMI, they also lose their menses. So irregular cycles, loss of cycles completely because of that impact. It's almost like a shock to the system is the way I think about it, where you don't have the sex hormones being produced, but also your body is just completely focused on trying to make sure you're surviving.
Okay. And so, you mentioned, starvation or even just, does that also happen even if someone is of normal weight or overweight? If they cut down their calorie intake, their caloric intake, would that have the same impact or is that a little bit different?
No, it actually has the same impact. And the best population that we studied that was in the bariatric surgery population. And so in that population, patients who have had gastric bypass, gastric sleeve, those types of procedures, we see a very rapid weight loss over a short period of time. So those patients are not necessarily extreme low BMI or in starvation, but the body feels it that way and they have that rapid change. There's so many hormone changes happening during that rapid weight loss time that we do actually see an impact both to reproduction, so fertility, as well as cycle regularity. And for that reason, actually the current recommendations are that patients who undergo bariatric surgery not get pregnant for at least 1 year post-procedure, which is another consideration. Pre-GLP-1s, we were really talking to patients about bariatric surgery as sort of not the only option, but the fast option. But when you think about, no, this is going to put you on hold for a year, then it becomes a little bit of a different conversation. So definitely, if you are considering bariatric surgery, you want to make sure you're talking to your fertility specialist. On the male side, I'll just put as an aside, because we haven't really talked about the guys tonight. But as an aside, we do see a very small subset of the population post-bariatric surgery, they completely lose sperm production and it's irreversible. We don't completely understand the mechanism, but we do believe it's something to do with like that shock to the system I was mentioning earlier.
Okay. Wow. Well, just so I can say you didn't just hear it from me. See, you're supposed to keep your caloric intake up to help with your health, even in your weight loss process. Well, thank you so much for joining me. This has been really educational for me as well. and I'm
Oh,
sure
good.
that, you know,
It's been
others
an
that, you know,
honor.
listen. And I would love to have you come back again. As you know, I'm sure I'll come up with a bunch of questions later, and I'm like, oh man, I wish I'd asked that then. But
Absolutely. I would love that.
so you heard it here, Dr. Carolina Swildo. You can find her at drcarolinaswildo.com, and also on Instagram, Facebook, and where else
Yes.
can they
And
find you?
YouTube. Yes,
And
ma'am. Thank
YouTube.
you.
All right. Well, thank you so much for having us, and thank you all for joining in as well. Good night.
Have a good night, guys. Thank you so much.